I'm Ann Curtis. I'm from the University at Buffalo in Buffalo, New York. I presented the results of the BLOCK-HF study. And BLOCK-HF was a study of biventricular pacing versus right ventricular pacing in patients with AV block and left ventricular dysfunction. This was a multi-center randomized prospective trial of patients who had AV block and LV dysfunction to see if biventricular pacing would be superior to right ventricular pacing, looking at a composite primary endpoint of mortality, heart failure-related urgent care, or significant increase in left ventricular and systolic volume index. We enrolled a total of 691 patients into the study and randomized them in a one-to-one fashion to RV versus BIV pacing. All of the patients had AV block, as I mentioned, and the majority of them had second or third degree AV block. Most had New York Heart Association class 2 to 3 symptoms. After the patients had the devices put in, they had their heart failure therapy optimized, and then they were randomized to the 2 different pacing modes and followed prospectively. Every 6 months, we did echocardiograms until the end of the study and followed them for the clinical endpoints. The main finding of the trial was that the primary endpoint of mortality, heart failure-related urgent care, and adverse LV remodeling was significantly improved in the patients in the biventricular arm compared to the right ventricular arm. In addition, we found that the clinical endpoints of mortality as well as heart failure-related urgent care by themselves without the echo endpoint were also significantly improved with biventricular pacing. Finally, we looked at clinical endpoints such as the Packer Clinical Composite Score, Quality of Life, and New York Heart Association class, and found in the case of the Packer Clinical Composite Score that it was better throughout the study, and for the other 2 endpoints of Quality of Life and New York Heart Association class, there were significant improvements at 6 months and at 6 and 12 months. So what we concluded from the study is that for patients who have AV block and left ventricular dysfunction, biventricular pacing is superior to right ventricular pacing in terms of the outcomes mentioned as well as clinical outcomes.